Good afternoon. Thanks for joining to this afternoon session. It's a sponsored session organized thanks to the support of Inside LifeTech. The topic we're discussing today is insight into coronary physiology. More specifically, what can a pressure microcatheter mean to us clinicians, to us interventional cardiologists, for clinical decision-making and PCI optimization. Join this session if you want to recognize how coronary physiology can complement clinical decision-making and optimize PCI results. To learn more about the role of pressure microcatheter in physiological assessment and to share the updates of this new and ongoing randomized clinical trial, the insightful FFR clinical trial. What's in the box? What is the session content? There is one mini lecture. We keep it to the minimum possible because what we like is to have an interactive session. So you are more than welcome to share your comments, experience, to pose your questions. You can do that through the app, the PCR app, or by taking the microphone. But whatever will be the kind of interaction you would like to have regarding this topic, we'll be more than happy to discuss that with you. We have selected a case of a physiology-guided percutaneous coronary intervention that will be presented by Carlos Collet. I don't see him yet, but he must be joining at any moment. And of course, integral part of the content of this session is your contribution. The team, let me introduce you with the team. My name is Emanuele Barbato, an interventional cardiologist from Rome, Italy. I'm the current EuroPCR president. Co-chairing this session with me, there is my good friend Adam Witkowski from Warsaw in Poland. Then we have Gianluca Campo from Ferrara in Italy, passionate about physiology like all our expert panelists. Kambis, Mashayekhi from Lahr, Germany. He's also passionate about complex PCI, not just physiology. Whatever is complex, Kambis likes it. Carlos Collet from Aalst, he will join, as I said, at any moment. And finally, but not least important, Salvatore Brugaletta from Barcelona in Spain. So to set the stage, the first obvious question, we are in the era, and this is actually more of a kind of provocation to my expert panelists. Why do we need to discuss in 2023 of an additional intracoronary device, so a pressure microcatheter, to assess coronary physiology? So let's have a round of opinions, starting from Kambis at the end of the table.
Yeah, Emanuele, it's a good question actually, but I think the major advantage is whenever you did some of those kind of PCIs with the FFR wire in, you might see that the wires sometimes get also destroyed, and especially when you do the pullback multiple times. And to have a device where you just can go over the wire has multiple advantages. First of all, the wire itself, the workhorse wire, is not so traumatic, can give you extensive backup as well. You have different kind of subset of workhorse wires, and so you can guide first of all your pullback, your measurement initially, and also afterwards your PCI, right? So for the PostPCFR measurement of FFR, and this becomes more and more important, I think, in nowadays physiology assessment as well.
The comment from Kambis is, for me, very valuable. As I said, Kambis is a super expert of complex coronary intervention, CTO, antegrade, retrograde, whatever grade. And he does it with all the kind of fancy catheters and microcatheters. So it is reassuring that you would see this device also to be used to guide PCI, not just to indicate the procedure. Gianluca.
Thank you, Emanuele. I believe that new tools are really important to support the penetration of coronary physiology because, for example, if we see in Italy, but also in other countries, the systematic application of coronary physiology to indicate the revascularization and to guide the revascularization is very low. So any tool that can improve the penetration of coronary physiology, so the possibility to improve the outcome of our patients patient is really appreciated. A microcatheter probably can be more familiar for a lot of operator, allow the increase of the number of assessment in daily practice.
So if I may summarize this midterm exchange of opinion, there is an unmet need in technical characteristics of the device at our disposal. There is an unmet need in adoption, so two good reasons. Carlos has just arrived, he's hydrating himself, so we let him drink, we won't disturb him. Salvatore, is there anything else you want to add on the very reason why we need to have this kind of session today?
Yes, I can only echo what it has been already said, and overall thinking about physiology in general. I guess that so when we implant a stent, I guess that the stent is already with the top level outcome possible. So what we need is to understand when the stent is something that we have to do. So we have to learn. So when the stent is something that we have to implant. And that is physiology, so that the physiology may help us to do it and to decide.
Last but not least, Adam?
Me, yes.
If you can come closer to the microphone.
Sorry. Yeah. First, we have in the guidelines that we should use FFR in intermediate lesion to know to proceed to PCI or postpone the PCI and treat patient medically. Second, we know that after angiographically guided PCI, in 2/3 of patients, FFR is not increasing up to 0.9, which does mean that it is the optimal result. So we should use again FFR with wire or microcatheter. It is equivalent because we know from the studies, from the SMART study, that these two methodology are the same, are equivalent, to know if we should optimize further. And I think it is a very important issue, which is not in the guidelines yet, but it is important.
So thank you very much. We heard, are you ready to share your opinion? Yeah, please.
So, thank you, Emanuele. So, I think that this device actually is coming along with the developments in the field of coronary physiology, where the pullbacks are becoming more and more important. And we're going to see this over the presentations, but one thing is understanding whether the lesion is significant or not, and another thing is understanding how to treat that lesion, and this is the value of the pullback. And this device is just helping us performing the pullback maneuver without losing wire position and making things a bit more easier. That's a bit how I see this connection.
That's actually an important step forward we are making nowadays in adopting coronary physiology in our practices. Not just to say treat or not treat, but there is a paradigm shift here. How to treat, where to treat, how many stents, when do we start, where do we stop? This can be done, of course, with intracoronary imaging. This can be done nowadays also with intracoronary physiology. I think this is more or less the consensus I could capture from our colleagues. So before handing over the word to Salvatore, let me just understand what is the unmet need here in the room by show of hand. Let me understand how many of you have at disposal in the cath lab pressure wire to assess coronary physiology. Raise hand, pressure wire. Thank you very much. How many now in the room have a pressure microcatheter to assess physiology? Any pressure microcatheter? Raise hand. Okay. How many in the room have angiography-based functional assessment? Raise hand. Excellent. So we've got more or less what is the status in the room. Salvatore, why don't you tell us what are the current trends in invasive coronary physiology?
Thank you, Emanuele. As you said, so we have to change a little bit the paradigm about how to use physiology in our daily clinical practice. So these are my disclosure. So we have to think that something can change from the past to now. So thinking about, for example, the 80s. So we were using physiology for analyzing intermediate lesion, but now so we are doing a lot of physiology, especially in trivessel disease. We're using not only in stable, but also in ACS stabilized patients. And many times so we use also the pressure wire as a workhorse wire for PCI. That is not always the best solution. But what is important, what I to stress you is the physiology-guided PCI concept, which is something totally new, so that was not present even in the past. So many times, I guess that you face a patient like this, so a three-vessel disease, so like you see on LAD, circumflex right coronary artery, many times, so you don't have any stress test of this patient, so you don't know, so if the angina, so is due to one of or maybe all these lesions, so you don't know if you have thoracic old, etc., and they are in trouble. And that is when physiology so may come to you, and it may be also your best friend. So, and to use the concept of physiology guided the PCI, so there are two particular points that I want to make. The first one is about the pullback. So we are not just discussing the fact that you are measuring physiology with just one value, so the famous value of 0.80, but the fact that after you have done this measurement, you have to do the pullback as well. And the pullback may give you very important information about the distribution of the disease, if there is some focal distribution, as you may see here in the middle, or a diffuse disease, which is going up, then you may see on the right-hand side. So if there is a focal or a diffuse disease, so something may be changed in guiding your treatment, because focal lesion is something that you may easily treat with a stent implantation, but if you have a diffuse disease, so either so you implant a stent, but you don't get the angina free to the patient, as you may see, for example, in this study, so made by Carlos. You see that if you focal angina, so with the focal lesion, you may have angina free to your patient, but with diffuse disease, okay, you may implant a stent, but nevertheless, the patient is still with angina, so you have to optimize medical treatment. So the second concept so is not only about the pullback that you have to do, but also to use physiology after you have made your PCI. So that is something that sometimes when you use the wire, so we change the wire with a normal wire, and sometimes so we are lazy, so we don't want to cross again the stent for making the PostPCFR, but it's something useful. No? You see here that in this study, so they recognize a threshold of 0.92, which is a threshold that may give you some safety and efficacy, some insurance about the outcomes of your PCI. And actually, so there was this algorithm, so which was showed in this paper, European Heart, that every time that you make a physiologist assessment after stent implantation, you do as well with the pullback, and then you have to measure the transgradient of this lesion when you have implanted a stent. And according to where this stress gradient the transstent gradient is located, so if it is located inside the stent or outside the stent, then you may decide either to implant in the first case, so to make a post-dilatation of the stent, or for example, if this gradient is located outside of the stent, you may decide to implant another stent to increase this gradient. So that is something that we should take into account if we want to have a physiology guidance 2.0 PCI. So according to this, so we designed together with Carlos and Emanuele, so this study, which is the insightful FFR study. So the study is going to enroll, already started the enrolling of the patient, 2,500 patients, either with CCS or stabilized ACS. So you see that any kind of lesion between 30 and 90% of the diameter stenosis by your eye, so can be included. So it's very wide range of lesion to be included, and the patient will be randomized, so either to the use of physiology by use of the pressure microcatheter or by the pressure wire, so the normal wire that we usually have in our lab. And what is more interesting about this study is not only, the comparison between these two different strategies, which will be in terms of non-inferiority, but if the patient so is going to receive a PCI in a second stage, so they will be again randomized to different strategy. One is the one that we use in our clinical practice, so standard of care, or the physiological, so induced optimization stenting, which is based on, as I showed you, the pullback, and then the post-procedure FFR measurement. So I guess that we have some cases later on, and Carlos also will go into details about how to use this physiology guidance. Thank you.
Thank you very much, Salvatore. Join us in the panel to have a little discussion on this lecture. Let's move a step further. We understood more or less what is your practice, what are the devices available in your lab. Now I'd like to know from you, how do you use these devices that are available? How many of you are using these devices systematically to diagnose, to understand whether a lesion is functionally significant, yes or no, and whether it needs to be revascularized? Raise your hand. Majority. How many of you is assessing physiology also after having treated the vessel, after having stented the vessel? Raise your hand. Slight minority. So-so. Time to time. I like the answer. He didn't say like this, he said like this. How many of you are using physiology also during the intervention? You know, much like we do with the intravascular imaging. Before, during, to assess several steps of the procedure, and after. Raise your hand. Less and less. Less and less. Is there anyone who would like to take the microphone and share with us the... Adam, you will help?
No, yes.
Yeah, thank you.
Somebody would like to take
Yeah,
okay.
I would like
So
to hear
okay.
from those colleagues who just said that would use physiology also after PCI. What is the value? Why do you think it is useful to do it also after PCI? Who wants to take this one? You just need to share your experience. That gentleman over there, I can tell you he will answer. His name is Dr. Pirot. I'm sure he will answer.
Thank you very much. Emanuele, I think it's first of all prognostic. We know that from studies, but to be really practical, I think we use it, or I use it for reasons that sometimes my eyes are just neglecting other lesions.
Well, that's nice. Say it again. Your eyes are neglecting other lesions.
Yes.
Why don't you trust your eyes?
Because I know that sometimes I think that this lesion is just moderate. But if it's situated proximal LAD or left main or proximal dominant right, it may prove to be functionally significant. So sometimes it's just mesmerizing to see, because people think about FFR as a tool to defer revascularization. And sometimes it's just a tool to prove that that point needs to be treated as well.
That's interesting. We used to hear that if you don't want to do a PCI, you just do physiology, but you're saying exactly the contrary. Anyone in the room who had this experience, you expected the lesion not to be significant, and you were surprised that it was indeed significant. Anyone? My friend over there is nodding. He's nodding with his head. Perhaps he can tell. No, over there, the gentleman who said like this with his head. You don't want to intervene? I don't want to force you. Perhaps the other gentleman over there, Dr. Sabate, would like to say something. You know, I need to encourage my colleagues to intervene. Huh? They try to hide, but I can catch them.
I think that we have to use it. We have plenty of experience of lesions that apparently are non-significant and become significant, and tight stenosis in a small area that become non-significant, and you can avoid the treatment. I think we have plenty of experience in both directions. So that's why looking is deceiving sometimes, and then you have to be sure that you have to treat the lesions. And during intervention, sometimes when you have several serial lesions, you can use the physiological assessment, put a stent in the more severe stenosis, then repeat the assessment to see whether the proximal one becomes significant or not, and then keep on the treatment. That I think this is the one. And of course, post-procedure is to be sure that the result is okay.
Of course, if you want to spontaneously intervene without an induced intervention, just raise your hand. We'll come and give you the microphone. Any comment here in the panel on what we discussed so far?
I'm interested in the issue, if you put a stent and you do the high pressure post dilation and you would like to assess the what is the final result, you limited it to angiography, or you do an IVUS, or you do a physiological assessment?
So the question is two?
Yeah. So who is doing just the final assessment based on angiography? Please raise your hand.
Be honest.
Be honest, yeah.
Be honest.
Yeah.
Raise the hands.
Who prefer to do an IVUS or OCT, intravascular imaging?
Prefers, that doesn't mean that you do it. If you don't have it, but if you could have it.
Okay. And who would like rather to use physiological assessment doing post-PCI FFR? Less.
We have to make this easy and quick. That's the point. We can say that in closed room, interventional cardiologists are simple people. We like simple things, quick and clean, if possible.
Speak for yourself.
I can tell you, many of them are sharing opinion. You see, there is colleagues who want to share the opinion. Can you give the microphone there? Not to Jolt, first to other friend there.
In our cath lab, it depends about the patient and about the lesion. if you do the pullback, because we have a severe diffuse atherosclerosis, I think it is mandatory to do pullback again after you have put 1, 2, 3 stents. So in these cases, we do regularly and have a pullback. And we stop only when we don't have any more to treat. So in these cases, I think it is mandatory to do again physiology on the coronary artery. And I think also those that have a catheter is better in this case.
To do in and out. I want to hear Jolt, and then I'd like in the meantime to invite Carlos to the podium.
Thank you. Just one more comment I would like to make. Of course, intravascular imaging is a perfect tool to assess how well the stent was deployed. But once we've done an FFR-guided procedure, it would be a shame not to use it to assess. And also, something that we have to remember, that very long stented segments tend to be underexpanded almost by law. And that is easily elucidated by post-PCI, good quality pullback. And that's the easiest thing to correct with high pressure balloon. So I think it's really, if you're there with a wire, why not use it?
Why not to use it? Carlos, before you start, we would like you to address two important points. One is a question from the audience.
Yeah.
You can just...
Yeah, I just can read it. It's actually two questions. So the first one was, which pressure microcatheter allow pullback, also co-registration? Assist doesn't. Is the lumen loss with the microcatheter not interfering with the measurement? I think it is important.
Okay, so these are the questions from home, and there is another important aspect I'd like you to touch or to facilitate in your part of the presentation. Our friend over there said a very important word. He said, we stop doing pullback and we stop stenting when there is nothing left behind. So we need to understand, what does it mean that we can be happy to stop intervention? A fractional flow reserve of 1? Or is there a threshold over which we can say, okay, we did a good functional, we achieved a good functional result? Word to you.
Good. Let's start with the last question, Emanuele. I'm going to address it right away because it's not in the presentation. I think that when we measure post-PCFR, there is something that we have to have in mind, that is the fact that when the patient is lying down on the table, the LAD goes upwards, and that creates hydrostatic pressure that makes the pressure in the LAD systematically lower than in the right coronary artery. So the normal FFR in the LAD cannot be 1 by definition. Exactly the opposite happens in the right coronary artery, because when the patient is lying down, the right coronary goes downwards, and that increases the pressure due to the hydrostatic effect, and that increases your FFR. I see sometimes our fellows that they put the wire in the distal right, which is a moderate lesion, and they say, we didn't equalize well, the FFR is 1.03. No, the FFR is 1.03. The pressure there is higher than the pressure in the ostium of the right, and that is a normal phenomenon that we have to get used to. So I think this is one important question. So don't try to chase a 1.0 in the LAD, because it's not possible. And that is one, I think, a very practical message. The second question, Adam, was about the microcatheter. There are 2 in the market, as soon as my knowledge concerned. One is the Assist, and one is the microcatheter from Inside LifeTech. The microcatheter from Inside LifeTech is a bit smaller than the one from Assist. So that is one element contributing less to disturbance in flow induced by the presence of the microcatheter in the vessel. So I think that those are the...
Well, we need to start the case. We'll try to address the question as we go. Please.
I have to disclose that the bar is in the middle of the presentation already, Emanuele, so please give me more time at the end.
Okay.
I will go. Good. So these are my disclosures. And the way that we have set up this presentation is with a case that was included in SciFull FFR in our institution. So this is a 71-year-old male. You see the risk factors on the screen. And stable angina class 2, normal renal function, normal ventricular function. And we're applying systematically this instrument called Seattle Angina Questionnaire, which refines a little bit the evaluation of angina and quantifies the angina in numbers. In this case, it was 69.72. But let's go to the case. We brought a simple case with a very interesting message behind. So this is a simple lesion in the mid portion of the LAD. You can see it very clearly. This is the steel frame to show you the mid LAD lesion. So no big surprise in terms of what the case will be. We perform angiographic-based fractional flow reserve. This is VFFR, showing a VFFR of 0.79 with a focal pattern of disease in the curve. But what I would like to spend the next few minutes is to understand how coronary physiology helps us predict what is going to happen after the PCI. And we're going to use two concepts that have been discussed by the panel before. One, coronary physiology has two steps. The first one is the measurement of the single distal point, and the second one, the use of a pullback. A single distal point without a pullback is half of the job. So you have to complete the measurement to understand, and I'm going to explain why. Let's imagine that we have this coronary tree. This is a left coronary system. You see it on the screen. And then we're going to understand what are the effects of PCI in patients with focal versus diffuse disease. To make the things even simpler, we're going to start with focal disease. And you see this proximal lesion in the LAD. And we put the pressure wire, and we start pulling back the wire slowly. And in the right side of the slide, you will see how the pullback curve will be behaving. As soon as the sensor reaches the lesion, you will see an inflection in the pullback curve. And if you keep pulling back the pressure wire or the microcatheter until the opening of the vessel, you will see a very large translesional pressure gradient. No surprise, this translesional pressure gradient is of course related to the presence of this focal disease, which again can only be assessed using coronary physiology. Now, what is important is what is going to happen now. We put a stent. This is a stent in the proximal part of the LAD. We're going to implant that stent there. And now look what happened to the curve. It normalizes. And now PostPCFR becomes 0.95. That's what we call high PostPCFR. Now, let me show you the opposite side of the coin. This is a patient with diffuse disease. We're going to do exactly the same. We're going to put a microcatheter or pressure wire down that vessel, and we're going to start pulling back the wire. And then we're starting to pull the wire back. Pay attention that the FFR in the distal part is exactly the same as the previous case that I showed you, 0.7. Then you keep pulling back the wire, and you see nothing in the pullback curve but diffuse pressure losses along the length of that vessel. You keep pulling back the wire, thinking that you're going to find a translational pressure gradient, but you do not. This is the definition of functional diffuse disease. The problem is that when we use angiography, we always find a place that says, here's the lesion. Here's the lesion. I can see it very clearly. Here is a more severe. This is the lesion responsible for the 0.7. So we might end up putting a stent. Of course, it's going to be a longer stent than in the previous case. And what is important is that after we place the stent, if we perform a second pullback maneuver, or if we look at the change in the pullback curve, this is what happens. Look at the curve. It remains diffuse. The FFR might improve a little bit. In this case, it went to 0.8. Now, what we have understood then is that patients with focal coronary artery disease are ideal candidates for PCI because the blood flow improved after the stent has been placed, and exactly the opposite happens when we implant the stent in diffuse disease. The improvement of blood flow is not significant. So let's go back to our case, and I have a few questions here for the panel. So we always start measuring resting indexes. This is our procedure in the cath lab. And in this case, you see this tight lesion, angina class 2, and probably for Gianluca, the CRR, which is the equivalent of any other resting index, is 0.9, and this is negative. So if you have a patient with angina, focal disease, and 0.9. So what is your next step here, Gianluca?
To perform
Hyperemia. Okay. This is exactly what we have done. So this is the FFR in that case. So it went from a negative resting pressure ratio to a FFR of 0.69 in the distal part of the vessel. We induce hyperemia in this case with intracoronary papillary. So how should we proceed? Well, next step is to do a pullback. We need to understand whether this 69 FFR will benefit from a focal therapy like PCI. And we go to pullback. I show you the pullback. I have this video is not working, but this is the pullback curve of that case. There is a simple or a single focal pressure drop in the mid part of the LAD. You see it very clearly. The maximal pressure gradient here in FFR units is 0.30. So this is a patient that would likely benefit from PCI. And this is exactly what we did. We also calculated the PPG index. You have seen that presented by Salvatore. This is an index that defined focal and diffuse coronary artery disease. And in this case, the PPG index was quite high, 0.74, pointing at the fact that this patient would likely benefit from PCI in terms of improvement in angina. This slide was already shown by Salvatore, but I just want to insist that we're very good treating patients with focal disease in terms of symptoms relief, but more than half of the patients that we treat with diffuse disease remain symptomatic after a successful PCI. So I like to say that these two elements of physiology, the distal point and the pullback, addresses two different questions. The first question is, does this patient need to be treated? And this is, of course, answered by the FFR, the single point, the 0.8 that Salvatore was referring at the beginning. But the question on how this patient should be treated is completely different. You see here two different pullback curves. The one on the left is a focal disease. The one on the right is a diffuse disease. And of course, you can imagine that would be what would be the outcome after PCI in both. So we have developed an algorithm to help us decide what to do in the cath lab. And this is something that we are going to look in the case. So in this case, we have a patient with a significant FFR. We do a pullback assessment. The pullback show focal disease, and there is a patient, again, that benefits from PCI. And again, we think that diffuse disease is better managed with medical therapy, with selective use of PCI or surgery for symptoms control. Now, let's go to the PCI, Emanuele. This is the predilatation, so predilated with platelet signs 3.023. This is the intermediate result. It looks pretty good angiographically. And then we said, okay, we believe in salt. We have to check with physiology. Let's go back with physiology. I put some questions, but we can discuss that later. Sure. Who would stop here? And I was just show the angio because it looked pretty good.
Raise hands if you would stop, please. Okay.
Very good. It's a good start. Good. Let me show you what happened. So the wire was already there. There was a normal work was higher. The wire, we decided to check the post-PCFR. Why? Because we know that patients that end the procedure with a low post-PCFR have a higher chance of dying or having an MI in the follow-up up to 5 years, and this is a continuous risk proportional to the post-PCFR value. So we measure post-PCFR. This is, again, CRR, 0.90. So again, didn't change. It was 0.90 before, it's 0.90 after. Now we do FFR, and the FFR improved. It was 69, 0.69, now it's 0.75. So it's a little bit better, but suboptimal. 75, you don't want to end the procedure with a 75. So what we did, again, we measured the distal point, now we do the pullback. And I have to say that this device, what allows for is to go in and out very fast. So it's really pushing it down, pushing it up. And this is what we found in the pullback. So a focal pressure drop inside the stent in an apparently good stent from the angiographic point of view. That was a signal to say, okay, we have to fix this. So we went back. This is an algorithm for the post-PCI assessment, and I'm going to drive you through it. So we measure post-PCFR. If there is a focal drop inside the stent, we expand the stent more. We post-dilate. If there is a focal drop outside the stent, we, of course, consider it a second stent. And there is a no focal drop, purely diffuse disease after PCI. It means that the procedure is finished. So we did a 3.56, high atmosphere dilatation, the proximal part of the PCI. The angiography looks the same. There's no change in angio. But we did measure post-PCI again, post-PCFR. And this is what we found. This CRR increased to 0.94, so now things got better, and the FFR increased to 0.85. This is the final pullback curve. now showing a complete flat line or diffuse disease, if you want to say, that is diffuse pressure losses. But again, no focal translesional pressure gradients that can be addressed either by post-dilatation or a new stent.
Carlos,
this is a summary of the case.
Hold on the previous slide, because it's an important point there. The reason why you decided to stop at this point your revascularization, it's because your FFR went from below 0.8 to above 0.8, or is it because of the shape of the pullback curve?
I think both elements play a role, Emanuele, but I think that what the pullback is answering is, what else can we do? And where? Where is the residual focal pressure gradient? Can we post-dilate more? Can we put another stent? And this is how we see these two metrics complementing each other. Okay, I think this is my last slide. So just showing you the evolution of the case. So before the PCI, 0.69 FFR, immediately after stenting with a very good angiographic result, but residual pressure losses only detected by physiology. And then at the end of the procedure, final FFR, 0.85. Thank you very much for your attention.
Thank you very much. Join us for the final discussion. There are several questions in the chat box. Please, Adam.
Yeah, I think there are two which are important in my opinion. First, maybe I would like to ask Carlos, is it possible that FFR measured directly after stent placement will improve after some times, days, weeks, as a result of vessel remodeling or resolution of vasospasm, etc.?
That's a very good question, Adam. And what could happen is when you do PCI to lipidic lesions, most of the time they're focal, you can have distal embolization. And if you have distal embolizations, this would mean that the microcirculation will be blocked by the debris of plaque that has been embolized after the PCI. If that happens, if you have a blockage in the microcirculation, all the pressure in your coronary will increase. So what can happen is that in those cases where we call it periposteal MI, if you measure troponin the day after, you will have an abnormally higher FFR than what would be after the resolution of the microvascular problem. So this is how this can interact.
And Carlos, further to discuss the issue of the different FFR measurement in RCA and LAD, there is a question. If there are such a variation of LAD RCA, why don't we have other normal values for RCA, for example, over 0.93 and LAD less over 1.87, for example?
That's a very good question. And you know, when we look at the data and we saw these results, the first thing that we did is we had a big meeting. We invited Bernard de Bruyn and Nico Pils, who are the father of this, and we showed them the data. And that was the first question. Should we think about changing thresholds? And then we had measurements of almost 3,000 patients worldwide with pre and post PCFR. What is interesting is that the amount of pressure losses, the amount of pressure difference that occurred due to the hydrostatic effects are very small compared to what could be caused by a lesion. So when we look at the pre-PCFR, was similar in the three vessels. Because the effect of the lesion is magnitudes of order higher than the effect of the hydrostatic pressure. So for the pre-PCI measurement, I think we have sufficient evidence to rely on the 0.8 cutoff. For the post-PCI, it's completely different. If the angiography looks good in your right coronary artery and you have a post-PCFR of 90, there is a problem. 90 is too low for the right coronary. Right coronary should have a 1. That's what you should expect, a 1.0 in the right coronary. In the left, in the LAD, is completely different. If you have an 85, as I mentioned, a 90, that's completely acceptable.
Let me involve in this discussion the gentleman over there. Jolt, you performed a pooled analysis of FAME 1, FAME 2, where you basically look into this aspect on what is the prognostic value of post-PCI FFR. What is the insight you can share from this analysis?
Yeah, it's moderate, to say the least. And I think one of the reasons for this is that if you apply a common cutoff value for all vessels, of course, an LAD just been shown by Carlos with a perfect angiographic result and a very good physiological result, will have a post-PCFR of 0.85. Whereas in the right coronary, if it's 85, you definitely either have focal disease or residual diffuse disease. So I think we have to have a specific, vessel-specific cutoff. So we cannot use it as a blanket cutoff value. We've just published our own experience from our center, over 500 post-PCFR measurements. And we show that there is a significant difference in the LADs and the rights only after PCI of 0.05 or 0.07 units. So why use the same cutoff value for all of these values? It just makes no sense. And of course, another very important aspect is the diffuseness of the disease. So it's completely different to have a post-PCFR of 0.85 if it's related to focal inside of the stent or outside of the stent, or if it's diffuse. The prognosis will be vastly different. And I think this is something that we never actually check for.
I have technical questions regarding this microcatheter. Is there any benefit of using it, especially if we use in complex coronary anatomy? I know each time I say the word complex, I don't know why I look to Kambis. I'm thinking to bifurcation. One stenting technique, two stenting technique. Is there any advantage there in assessing the main branch, side branch? Is there any value?
I mean, honestly, in this heavily calcified lesion, you might have also a problem with crossing, right, as well, like low-profile balloons. I mean, we have to be honest with what's going on, right? But in terms of struts crossing, especially when you think about a circ, a left main PCI, where we see a much more over treatment, especially on the ostium circ, where we have a actually not perfectly solved scenario at the moment, especially when we have calcified nodules there as well. I think it's really worth to check if it's necessary to go further on with a two-stent strategy. So still, I think data, I don't know, please, Carlos, if I'm saying something wrong, but I'm not sure about data at the moment. At this part, I don't know them, but I think at this point, it's absolutely reasonable. And as well, another thing is once you bring the patient back and you do a reassessment, what's also interesting, if you see some in-stent restenosis on the circ as well, is just do an FFR and see if it's relevant before you heating up again the process. Because oculomotorically, you want to do something, even say 75-18% QSA, and you think you have to do something. But if you make the FFR measurement, you will be surprised how often you can treat these lesions, even conservatively, with in-stent restenosis.
Adam.
I think that the advantage of the microcatheter, okay, I will use this one, is that you can keep your wire in the same position in the coronary artery. With pressure wire, you have obviously moved the wire. It is not very easy. It is not a very user-friendly device, a bit stiff. You can damage the sensor and so on and so on. With microcatheter, you keep the wire in the same position and only use the microcatheter, exchange for another balloon on stent, and again go on the same wire with the microcatheter to measure FFR. So I think from the operator point of view, it is a big advantage.
And as well as you think about multivessel disease, right? Because sometimes you end up with using two wires if you just have to measure all the free vessel and free vessel disease, and that's really a great advantage as well.
I just have a little time left for a last comment, either from Gianluca or from Salvatore. You were both very quiet. You decide.
No, from my experience, the major application of the microcatheter is in multivessel disease because the procedure go very fast and easier. It is really important in the pullback, as suggested Carlos, to focus the attention in diffuse or focal drop. It is important especially in the post-PCI assessment, and not search for the value, but search for the pullback curve to avoid to leave in the vessel some focal spot.
You were quick enough. We got the bonus. Salvatore?
Yeah, just a small tip about the pressure wire. So we talk a lot about the distal tip, you know, to preserve the pressure sensor, but also the proximal tip is the one that we use for crossing balloons, stents, etc. And that is the tip we need to connect, so to make the measurement. And sometimes, so although the pressure sensor distally, so it works, so we break this proximal tip, and we are not able to connect again with the console to get our measurement.
Thank you, Adam. I think it's time to conclude. to draw some conclusive remarks. I must say thank you very much to all of you, because I learned quite a lot this afternoon. I learned that there is a place for physiology, not just to indicate revascularization, but also to check the result of our revascularization. But even more, we can guide our intervention. That is something really to be considered more and more. We have a tool, we open it up, it's there on the table, let's make good use of it. And secondly, this device seems to make our life easier, because we can go back and again within the vessel while we have just entered the vessel safely, without major problem, and again very quickly. So we can assess multivessel disease, complex coronary anatomy, calcified lesions. So we're just looking forward to see the results that will be available, I guess, in a couple of years from now, of the insightful FFR trial, to see whether we have also solid data to substantiate our reasoning today. With this, I thank you very much, and I wish you a good evening and a good continuation of EuroPCR. Thank you.
Great conclusions. Congratulations. Congratulations to you.